Well, welcome, 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 everyone. As we get ready, we're just going to wait a couple more minutes and get people to enter. If you're here, I invite you to put your name and your location in the chat. And welcome to this PallCHASE webinar in the month of October as we remember World Hospice and Palliative Care Day. Okay. And a few more people have entered. Welcome, everyone, and invite you to put your name and location and a greetings for World Hospice Day, Hospice and Palliative Care Day in the chat. Hey, maybe we'll give it one more minute, everyone. Welcome, welcome. Okay, I think it's 3 minutes after. And again, my name is Rick Bauer. I am on the executive committee of PallCHASE, and on behalf of Aaron and Joan and Moira and Nala, to welcome everyone to this quarterly or October um, PallCHASE webinar. And we're doing this in the month of World Hospice and Palliative Care Day, where our theme is achieving the promise, universal access to palliative care. And I'll talk a little bit more about PallCHASE after our wonderful presentation. But to remember that universal does mean everyone, including people in humanitarian emergencies, in war zones, refugees on the move, both international, and internally displaced people. So we'll talk more about that. But without further ado, I would like to, and it's my privilege, to introduce Dr. Nahla Gafer as our speaker, who is actually with us from Afghanistan today. But I'll let her talk a little bit more about that. I believe there's a video to start with, and so I'll have Erin start with the video before Nahla begins her presentation. Thank you, thank you. Technology actually worked, at least I could say it and hear it. So I would like to now introduce our speaker, Dr. Nahla Gafer, a palliative care physician, oncologist, and just human being extraordinaire. Nahla, welcome.
Thank you so much, Dr. Rick. It is wonderful to be today with you and wonderful to celebrate with you World Palliative Care Day. In fact, the video that you all saw was a simple and activity done in Aden. It was the first palliative care clinic to be opened in Aden in Yemen. So without further ado, I will go ahead with my presentation. As mentioned, I'm an oncologist and also a palliative care specialist, and I'll be reporting about some activities happening in the Eastern Mediterranean region.
Dr. Nahla, are you sharing your screen? For me, it's showing black.
I'm supposed to be sharing. Okay, let me share again.
Yeah.
So which slide do you see now?
We don't. It looks like it's still trying to share.
Okay. Maybe I don't have permission to share.
You do.
It says your screen sharing is paused. Okay.
Try one more time.
And now it's the same. Let me do something. Okay, maybe okay. I click away share sound and optimize for video sharing. Let's see.
Up.
That was coming along better.
Yes, but it's the wrong screen. And now? Nothing? Okay, so maybe Erin, we share from your
Yeah.
side, no problem.
Yeah.
Yes, so welcome all, and I'm very glad to be with you today in celebrating World Palliative Care Day, and it's a pleasure to have contributed also with this small activity that is happening in Yemen for the first time. It's a palliative care clinic opened recently on the 13th of October, and my name is Nahla Gafer, and I'll be speaking about some activities happening in the Eastern Mediterranean region. If we can go to the next slide. I will be speaking about three things, in fact. A little bit about the Eastern Mediterranean region, about the needs of palliative care there, and the experience of provision of palliative care in conflict situations. And most importantly, something happened on the 16th of October, which is last week. It was a resolution has been passed at the WHO office at the Eastern Mediterranean for the Eastern Mediterranean region, and this resolution will impact the services, hopefully positively in palliative care for the 22 countries there. So we go ahead. Yes, so this is the region I'm speaking about. It's 22 countries, stretching from Morocco and going up to Pakistan. I am currently in Afghanistan, in a small city called Kunduz, where I'm also being involved in capacity building for palliative care. Next. But if we look at the situation of palliative care in our region, is a little bit, you see very clearly it's under compared to other parts of the world. We have 22 countries with a lot of things in common, the culture, the religion, language. So most of these people speak Arabic language, but as mentioned, palliative care is very underdeveloped. Next. So we did a mapping of reaching out to palliative care services that was in 2023, and trying to identify where the palliative care services are and what models of service they are providing. Is it hospice care? Is it palliative care units in hospitals? Is it palliative care units in oncology centers? And if we go ahead, we managed to identify, I think, about 67 services in the region. This is still not published because we want to bring it as an activity from WHO, so we were waiting for the resolution to come out, and we are going to reach out to the member states officially and having them endorse this map. So the idea is to have an interactive map where policymakers, where patients, where health professionals can click on the service and they get information about this service. Is it providing palliative care for adults or children or both? Is it outpatient service? Is it inpatient service? Is it government funded or not? The team members, when it started. And you can see in this provisional result, there are 1, 2, 3, 4. I think it's even, yes, we have Djibouti here. So 1, 2, 3, 4, 5, 6 countries with no known palliative care service. Okay, and now we are happy that Yemen has got something, and next, after a month or two, we have something in Afghanistan. Good. So the other thing I would like to speak about is palliative care during conflict. Now I'd like to bring the example of Sudan, which I have witnessed. So we had the palliative care service that started in 2010 at the main oncology center. And we formed a very wonderful team. Below you can see the photo. We were celebrating purple tea party. I think it was an idea from Cardias, and everybody of the team were wearing purple and taking a photo together. So we have the doctors, the nurses, we have psychologists, even we have the statistician with us. And we were seeing about 500 newly referred patients to the palliative care unit. And it was mainly for cancer patients. So established unit, we have in-beds, we have outpatient, and we also have home care. And then what happened on the 15th of April 2023, out of the blue, we heard bombing, and it's a start of war. And people start moving around, so people were fleeing. I left the city after 4 days from the start of the war. And unfortunately, other people stayed for a longer period, but we're faced with a lot of difficulties. So there was huge difficulties, not only for patients, but also for health professionals. There was lack of cash, there was no transport, and the most important thing was the danger of life, but also the lack of services. So patients couldn't reach to any health services. Pain medications were entering, and now we are almost 2 years and more after the war, and this is the situation. Next. We have almost two groups of people. There are people who stayed inside the city or inside the country, and people who left and traveled outside the country. So those who stayed inside the country, especially in the war-stricken areas, are facing extreme living conditions. As I mentioned, the prices increased. Everything is more, I think even 10 times more expensive. But also their body becomes weaker with poor nutrition, and also outbreaks of infectious diseases. You can see here, this is part of a hospital, and these are men lying and getting infusions, because there is outbreaks of dengue fever, outbreaks of cholera, outbreaks of malaria, and of course lack of medications and medical care. But also those who left the country and went outside are facing difficult situations. They are away from their normal social environment and their work. So they're not usually offered for job opportunities. It's very difficult to find job. And we also recorded some incidents of suicide for these people, because everything changed totally. Instead of living in your house, having your job, having your car, you become a refugee. And some people are living in the streets of cities and looked down by people. They have certificates, but they can't contribute to anything. And that is very important to provide palliative care during humanitarian settings. And we also found that health professionals are also a target for psychological support. Next, please. So what did our palliative care unit do? First thing, we tried to reach to ourselves, to the different members, and give them advice about security and about movement, encouraging them to go to safe places. We had a difficulty with some members who insisted on staying in their homes for 3 and 4 months until it became very dangerous for them also. And we also reached to our patients, giving them practical advice. We had patients who were on chemotherapy, or patients who were needed to have radiotherapy, for example, for brain metastasis. So we were giving them the advice where to access these services, what's the best city to move to. And we began rewriting our notes, because we depended on a computer system. We depended on our files, which we couldn't reach anymore because of the war. So we reinvented another ledger. We started writing, we call the person, we get the history from you, and we see what do they need and how we can help them. especially with pain medications, because morphine was not available. And so we had to do other substitutes. For example, if there is tramadol, or if we add paracetamol and diflunac together just to get the maximum effect. So we formed a network, and there was this Project Sunshine during war. It was a generous collaboration with Caritas International and Senate Hospice for Palliative Care. This is a Lebanese NGO, so they were supporting our staff psychologically, running one-to-one sessions and group sessions. And even together we had some videos, training sessions about first aid and how people can help others. So these were also posted on YouTube. And so after the war, we reached to about 800 plus patients. And our team members dispersed. So we can think it about the watermelon. We have a watermelon, you break the watermelon, and all the seeds are moving around. So we have some doctors and some nurses in different cities, and they started providing palliative care. Also, thanks to PallCHASE, they supported us during the last 2 months. And so when they are providing palliative care, they're spreading palliative care, and they become a source of trust and confidence for the community, for the local community. So they are reached by people who are thinking they have cancer, for example, they have complaints, they reach to these people, to our team members, and our team members have a link with the hospitals, they direct them, and also they provide palliative care for them. So it's early integration of palliative care. And our plan is to train more health professionals to increase our team. Currently, we have 5 attending online courses in palliative care, and so we'll spread the services for palliative care during these difficult times. Good. So I think now I will go to the last part of my presentation, and it is about very important resolution that came out on the 16th of October. That was the hard work of the NCP department, or NCP unit at the regional office in Cairo. And this resolution is going to be like a very important base for the services in the region. The first thing that happened when this resolution was discussed was, what are the needs? If you can go to the next slide. Yes. So we identified the needs. The needs in the region, we have 2.4 million people who need palliative care but don't have access to it. In fact, only 1% receive palliative care. And we identified that this 1% was mainly for cancer patients, and mainly in tertiary centers in the capitals or in the big cities. But as you see on the right, you can see the different diseases. These are the major diseases for which palliative care is needed in the EMR region. And you can see that cancer forms less than 30%. Other diseases form more than 70%. So it really needs that we have to think broader. We have to speak about all diseases, all diagnoses, all settings, and not forget that this dual burden of increasing chronic conditions, but also the humanitarian settings. Humanitarian settings increase the need for palliative care because people in humanitarian settings, especially patients, don't have access to the services, so they have more suffering. Their diseases will get more advanced. Okay, and there is other factors that affect them. There is psychological issues, social issues. So all that call for more need for palliative care. And please, next slide. Yes, so when this technical paper was not developed out of the blue, there were some steps. We based our work on the World Health Assembly Resolution 67.19, which calls for the integration of palliative care into universal health services. And in 2019, in the Eastern Mediterranean region, an expert network for palliative care was formed. And one of the most important things that came out from this work of the expert network was initiation of blended courses in palliative care. These blended courses are online sessions given usually once a week, but with other activities requested from the trainee, so that the trainee, for example, assesses a patient every week and he uploads the assessment, or he has interaction with the trainers through the model doing assignments. So they're solidified by activity by the trainee. And in 2024, we have very important papers published. There was a WISH report that came out in Qatar, and it shows that 10 years after the resolution, still we have limited progress in palliative care. And this year, the most major activities in 2025, from February, there was the suggestion of having the resolution, and there was a draft paper, technical paper written, but also we had important stakeholders meetings. So we had meetings with each of the 22 countries, and we managed to reach to 20 countries. We asked member states to bring in 5 major stakeholders from every country. So we will usually ask for Ministry of Higher representative from Ministry of Higher Education, representative from the pharmacy department, primary health care, oncology services, NCD management. If there are palliative care, if there's a palliative care association or palliative care providers, they will be included also in this meeting. And we discussed with them about the framework for the resolution. And in July, there was a official member state consultation. And so this is through the governing bodies department in the WHO. So they reached officially to the member states, and there was we can say, a delegation attending online this elaborate discussion. And on the 16th of October, the resolution was discussed, and it was unanimously passed, and with very important input from member states. They all solidified the major point about the importance of palliative care and the way forward. So we can see here, if you go ahead, the next slide, yes. So these are the highlights of the resolution. We can see they are divided into 6 major areas. In the area of governance and policy, there was the importance of having national strategies in palliative care in each of the countries, and having a focal person or a focal task force at the Ministry of Health involved in or with the task of developing palliative care in the country. There should be dedicated funding for palliative care at the different levels of the governance, like the central government and in the different provinces, and palliative care should be included in the universal health coverage. Then we go to the area of service provision. The resolution stated that palliative care should be provided at all levels of the health system, at primary, at secondary, and at tertiary. And it should be embedded into existing programs, so integrated in oncology, in NCDs, or pediatrics especially, because in our region also pediatric palliative care is very underdeveloped. Then for communities, we have some countries who already have some palliative care, especially at tertiary centers, but reach to communities is little. So there was an emphasis on the involvement of civil society and promotion of compassionate communities, and starting these discussions about death and grief literacy. And then this fourth item is very, very important. Access to medications, especially oral opioids. We identified that we have some countries with no oral opioids available for the last 3 or 4 years. And there is need to revise restrictive regulations and ensure that essential palliative care medications are included in the national essential medicines list, improve access to oral opioids because sometimes it's available in certain centers, or even in those centers it's available for very short periods. They give it to a patient for 1 week or less than sometimes 3 days, or only to inpatients. And the importance of monitoring opioid consumption. Not only that, but also monitoring any shortage. So especially in the country, if in a country there is shortage of morphine or tramadol for a certain period, it will be reported. And the fifth one is the workforce. So the importance of education and mandating palliative care training, basic palliative care training at all undergraduate levels for doctors, for nurses, and if possible, allied health professionals. And also inclusion of palliative care, advanced palliative care in postgraduate levels. Recognize the qualifications in palliative care, because sometimes we already have people who are qualified in palliative care, already people experienced or trained in palliative care, but there's no difference between them being trained in palliative care or not doing anything. So we need recognition and the creation of career pathways. And this is the way to accommodate these people and to make sure we are making use of them and we are expanding on services. And the last area is about research and surveillance or monitoring. So we need to integrate palliative care indicators in the routine health system and generate evidence on cost-effective models of care. So there will be some funding for research. Track, yes, this I already mentioned. One of the major activities is tracking any shortage in oral opioids and give priority to research in palliative care. Good, so these are the 6 areas. And we go to the yes, so this is the role. We are calling for health professionals, especially health professionals who are in the region or are friends of the region, to help and to support us by advocacy for policy inclusion, capacity building and training, expanding services and integration, data collection and research, sharing best practices, evidence-based policy support, and also giving us examples in community and home care models. I think I come to the last slide.
Good. Yay!
Thank you so much. And I'm ready for any questions.
Well, thank you so much. Before we get to the questions, I'm going to do a little, because I'm chairing, so I get to talk a little bit. And I saw the note in the chart. I'm just, amazed, about how we can provide palliative care even in situations that look hopeless. Because in the DNA of palliative care is there's always hope. There is always hope. And so many of us, we know, people ask, any of us attending this that are in palliative care, and people say, oh, what do you do? And number one response is, oh my gosh, I could never. How do you deal with that? How do you deal with dying or dying children every day? Because they haven't tasted that hope. So I just thank you for being that beacon of hope. I encourage all of you to, if you haven't read the palliative care resolution from 2014, it's a landmark document. It's revolutionary. And now we're having webinars on 10 years into it. It's still a great document, but we still have to make it real. I am so grateful for all of you being here well, this morning, this afternoon, this evening, depending on where you're at. Just to do a little bit about PallCHASE before we get into some, hopefully we'll have plenty of time for discussions and questions. PallCHASE is this global network where we want to see a world where everyone, the emphasis on everyone, affected by even humanitarian situations, emergencies that have health-related suffering, have access to palliative care. So way back when in 2016, when this began to be forming, we had different global entities, the Worldwide Hospice and Palliative Care Association, International Children's Palliative Care Network, the International Association of Hospice and Palliative Care. But we noticed in 2016, when we saw that horrendous, fleeing of refugees from Syria, what's being done about palliative care in humanitarian settings? And the answer was very little. So a few of us, some of us on this call, got together with no money, no real deep vision other than a passion to bring care to some of the least. And so we started PallCHASE, and our dream was to have this collaboration between palliative care and humanitarian practitioners. Because many of us in palliative care, when it came to real disasters, we didn't know exactly how do you work that system. And many of our humanitarian colleagues were so focused on triaging and saving lives. But what do we do when we can't save that life? And so we started PallCHASE, and we started kind of this ragtag group of people that keeps meeting and keeps hoping and keeps advocating, communicating, educating, and researching on how do we get palliative care to some of the least in our communities. Because the goals of humanitarian work and the goals of palliative care is to relieve suffering, to eliminate that human suffering. And we can do that, again, through good ethical decision-making, by setting goals of care and having those goals of care conversation, by managing the whole person. And Nahla spoke so beautifully of that. We do need, and we've got to have access to opiates and analgesics and pain medication, but it's managing the emotional, the moral, the spiritual distress that often comes with humanitarian, disasters. It's dealing with those really, really, really difficult conversations. That's what we do in palliative care, It's working with neonatal palliative care and saying how important, because we know in disasters and wars, we have a lot of premature births, and we have neonatal palliative care. We have a lot of bereavement support and people grieving not only the loss of life, but maybe the loss of their home, the loss of their dreams, the loss of their families. And then palliative care, when we're really at our best, we do so well at staff support. And how do we take care of each other so that we can continue in this? So palliative care, so PallCHASE, as kind of a ragtag group of people, we keep going. We offer some quarterly webinars to get people involved. We have a membership. I think, Erin, it's over 600. Some people come to the webinars, but we have committees if you want to get more involved. We have tools to help you get involved in your country, in your region. because all of these regions look a little different and the needs for palliative care. But all of us, there's over 300 million people on the planet right now that are in some kind of humanitarian situation. Not all of them need palliative care, but some of them do. And PallCHASE wants to be the advocate for those folks, and then hopefully have this marriage. I think we're engaged now, but we need the full marriage between humanitarian and palliative care, that we can come together and offer the best of both of our areas. That's my PallCHASE blurb. Have I forgotten anything, Aaron or Moira or Joan, if you want to jump in before we get to some questions and discussions for Nahla?
I think you covered it beautifully, Rick. Thank you.
So what we still have some time. I'd love if you have a question, a comment, for Nahla on her presentation on the incredible work that she has done in the Mediterranean region, in her home country of Sudan. And now in Afghanistan, if you have questions or comments of the how-tos or what she's done, questions about what you can do. How can you bring this to your country, your region? That you can raise your hand. We're pretty informal group here. You can just kind of jump in if it doesn't get too crazy, but unmute yourself.
Sorry, I'm just going to say there's been a couple of comments in the chat already, really around the need for primary care and home-based care, but also the financial pain that can be caused by the chronic disease itself. So I wonder if that might be a good place for Nahla to start, and I'll keep an eye on it.
Perfect.
I would like to mention that the vision is to change how, like, the health system or the health professionals look to patients. The idea is to think of them like you treat them as you would like to be treated yourself, and support them as much as possible. So for us, patients who are poor or financially struggling, these are the people who need more of our attention and of our support. And a lot can happen, a lot can be done. I will give an example in Yemen. So a few years ago, they formed a fund, and this was for cancer patients. And when they did this fund, all cancer patients now receive their chemotherapy for free. So even in poor countries and low-income countries, looking into patients' needs and thinking, how can we solve it? A lot can be done. And the other point is mentioned is home palliative care. Yes, inclusion of palliative care into primary health care. Yes. So the basics, when we have the basics of palliative care provided by all health professionals, provided at the primary health centers, we have the complicated issues to be seen by the specialist. And I think a lot of palliative care associations and societies all call for this approach about generalist palliative care and specialist palliative care. Unfortunately, in some countries, especially in the EMR, we have only specialist palliative care. And the people wait, and doctors wait till the patient is approaching to end of life, and then they think of referring them to palliative care. And this will emphasize that it will make a big barrier for people who are providing palliative care, and also for patients. Patients will refuse to go to palliative care services, equating it with giving up. But we need to think about palliative care of supporting the patient. The earlier, the better. And whenever there is need, whether it's before this or after this or far before this, palliative care should be there.
Beautiful. Couldn't agree more, but that's why Nahla and I just loved listening to her all the time. I had a young medical student that I just love this, that just told me that what she wants to do is transform healthcare systems into caring systems of health. And that's what palliative care, I think, can really do. I completely agree. I spent 25 years in Africa. I am, the broken record on home-based care and community-based care. And I think, especially during the early HIV years, we saw how this can be done, even in incredible restrictions of resources. And I saw, faith communities and mosques and churches getting together and buying a community health worker a bicycle or giving them some phone credits or data support so that they could talk with the nurse who was trained by the Ministry of Health who supervises the community health workers. So I love that comment. And, about that community home-based care, is the way to go. Because I'm chairing, but I'm just doing a presentation on this. What's the difference between the general and the specialist? Really important question for everyone. And I think, again, palliative care can teach the world how to do this. Because in palliative care, we have the bio, psycho, social, spiritual model of care. Okay, well, Dr. Nahla is the specialist and Dr. Moira on the bio, okay? I'm a board certified chaplain. I am the specialist, on the spiritual domain. But everyone on the team needs that basic knowledge. I got to understand, what's the difference between tramadol and morphine, and don't know how to do it. I need to be able to do a pain assessment, but that's all I can do in my scope of practice. Within larger, I think what we need more of is both pre-service training in our schools of nursing, schools of social work, seminaries, and our medical schools. But then we also need that in-service training. So we can create generalists. Someone might be an internal medicine physician, a general nurse working on a surgical ward, but we can get her to be, or him, to be a generalist in palliative care. Then we also hope that people get more advanced degrees, a master's in palliative care at different institutions to become specialists. And since I just jumped right in because I love this, Moira, and you're so involved with education, I'll leave this to you.
No, there's great discussion. I was just going to add to that. I think what we're talking about is about competencies. So what people are able to do. And I see some great comments coming from different settings where you're talking about nurse-led programs or integration into the community. But I love what Rick just said. Actually, we want everyone to have the basic competencies in palliative care in any part of this caring health system. I think it's a great term. And then we want to then have a competency-based way of improving that. Those who look after a lot of people with chronic illness and serious health-related suffering, wherever they're working, let's give them a few more skills. I know Nahla, and she may mention it, has been doing a fantastic online program in the EMRO region, for example, to build those skills. And we usually call those level 1 and 2. And then we get to level 3 and 4. So I would say that everybody needs to have the basics of holistic. I wouldn't like to be called a palliative care physician, but there are some that have, extra special, like super special. So I would just really emphasize the integrated nature of this, that most palliative care will not happen by somebody with a specialist label, that we all need to be competent in the basics of palliative care and then build those competency levels depending on where we're working and the patients we're seeing. And that must be multi-professional. It cannot be one profession alone, and we mustn't miss out. As Rick has quite correctly said, the social and the spiritual, it must be combined. And I love the fact that education is getting a big role here. But I think you've got some other comments in the chat there. And Moja, by the way, Rick, just so you know, is a colleague of Nahla's who's joining us from still within Sudan. She's gone back to Sudan and is working, and she's got a comment she's making there. She might want to make that comment orally if she's asked. Moja, do you want to make a small comment?
It's okay. Hello, everybody. It's a pleasure for me. Hello. It's a pleasure for me to meet you all today. And yes, I'm back to Sudan now. And let me tell you, even the situation is worse and worse. We know before war, as Dr. Nahla mentioned. But I think we have to focus in this a period of time on the community and the people, because they are there, they are ready, they know the needs, they start to recognize the needs, knowing that our health systems are very weak, and maybe they are focused in another area. We know that in Sudan there is a epidemic of many diseases like dengue fever, malaria. Even it start to come in a more aggressive form and more complications. And now we are expecting leishmania, chikungunya, and other type of acute and epidemic problem. So now we are focusing on getting the community with us. We are training volunteers. We are reaching the communities. I'm in the east of Sudan. Port Sudan is an state in the east. We can say it is safe to some extent. Now we don't, for a long time, we didn't see any drones or any pumping ore. So we are involving the community with us, training many of the volunteers. We are focusing on those who have a medical or nursing background, so they can do some service like wound care, lymphedema care. But for the rest of them who don't have a medical or nursing background, they provide social support, spiritual and psychological support. They are doing very well. And I think this is one of the way that we can help our communities in these complex times and this humanitarian complex settings. This is what we are in now in the middle in Sudan. In the middle of that, we are trying to do some maybe surveys and research. Maybe 2 months back, we started to do a survey in the Port Sudan state about the health situation and the palliative care, also situation among health professionals. And as expected, the situation is very poor. The health situation is very, catastrophe, and the need is there, and it's increasing every single day. So I think for us being here, staying here, doing anything, no matter it's small, it will help the people of Sudan in the right time. And if it is allowed for me, I would like to thank Company for their continuous support, ABCA, PallCHASE, the experts from around the world, the ISBIC, Dr. Rick, Dr. Nahla, Dr. Moira, all those who will continue supporting us from the beginning and until now. So thank you, all of you. Thank you so much.
One thing that I was thinking this week is how we, obviously Moja, it's very inspiring. Dr. Moja, it's very inspiring to hear you speak. And there are many of us that are not in places like Sudan within PallCHASE. And I know we've got about 30 people on the call today. I think I counted maybe over 10 countries represented. One of the roles that for us within the greater community of those wanting to support within humanitarian settings is also witnessing the work that is being done in extremely difficult situations. I recently was on a call with a provider who probably for the first few times experienced that compassionate communication, shared difficult news, and then she was sharing about how the patient eventually had died and how she now is continuing to support the family. And I think those are huge steps for someone, for example, with generalist palliative care training, just giving difficult news, processing the fact that a patient may die, and then the patient does die. People on the kind of outer circle, even within PallCHASE, if there's ways we can witness with that and listen to that and support providers that are doing it, I think it can also be quite lonely. If you are a provider and you provide really high quality care and nobody is there, like it almost even like case discussions when we do that in many of the trainings we offer, Dr. Nahla and Dr. Moira offer, when we can witness when people do really amazing work, I think that also empowers them to do it again. Because I think, again, in many of these conflict settings, it can be very isolating, and you can try to implement some of the new skills that you've learned, but it can be really challenging. So I would put this call out to those of us that are that are still within this community, finding ways for us to support those that are on the front lines, witnessing the work that they're doing and continuing to encourage, I think is also a really important call.
I'd like to add to that, to what Erin has said. You know, after nearly, oh goodness, over 4 years of keeping in contact with colleagues in Ukraine, how often when I ask them what has helped them to keep going, to keep on doing palliative care, to go back to their apartments or homes that have been destroyed. And they say two things. One is faith, and the other is knowing that people care and just keep contact. And so I think, as Erin said, sometimes when we feel we can't do anything, just reach out and say, how are you today? Is there anything? Do you want to talk? And just listen to the huge challenges that they have. And yet, in spite of that, they continue. And to me, it actually gives hope. It just shows that the human spirit is invincible. And that, you know, no matter how dark the situation is, that people can get through. But of course, the immense suffering that they go through in that time is overwhelming. And so if you've met somebody at a conference or had an email contact and you know they're sitting in a conflict situation, a climate crisis, they are displaced. And I remember, Nahla, when you were displaced, when you were traveling, how you said just the people who kept contact with you is just, you know, with technology, it's so easy just to reach out and say, I'm thinking of you. How are you?
Nahla.
Thank you. Yes, thank you, Joanne, for reminding me. Like when we receive just this message, a text message or a call from somebody from far away and just asking, how are you doing? It gives us a lot of hope. And Dr. Mucha might also concur with me on that. And that is why we are reaching to our patients. I know Dr. Moira doesn't agree about the frankincense oil I'm bringing to one of my patients. So my patient's having some advanced squamous cell carcinoma, he's albino. Unfortunately, it's very, very late, and I'm far away. And in Botswana, I heard that neem oil will help in healing. So I texted him and I told him, I'll bring you some oil with me. And I told Moira that it's some encouragement. He feels hope, although it's not. He feels that I'm still thinking of him. And that's why I'm doing it. I just want to bring it to attention, also coming here to Afghanistan. I heard from my colleagues that their country has been in war for the last 40 years. So in Sudan, we are in war for 2.5 years or something. But in other places, continuous war for 40 years, what is the effect it has on the health system? You know, whenever they build something, it's destroyed again. But the good thing is that the health professionals are so keen. They feel what is happening with their patients. They feel the need. They feel that something is missing, and they are very receptive of training. And I hope we can do a difference. Thank you.
Thank you, Dr. Nahla. Excuse me. Andrew, Adek.
Yes, maybe me, I wanted to just give a small just experience since all the time I've been working in South Sudan. And sometimes it's very difficult to bring people together, to bring the health worker together when there is a lot of politics and a lot of maybe misunderstanding in the government. So we find that wherever we are working, it gives me much more challenge, like the organization that I'm working, that to try to educate and tell people what really palliative care is. And in practical, really see these patients and try to discuss with them, discuss with the family. And that's how because when you just come, you just greet a patient and tell him, okay, he tells you maybe I need something for pain, and you struggle for this person. Sure, you feel that you are getting somewhere in a little way. These community health workers, they go to the community, they do public health mobilization, they see the patients in the community. So as we tell them what really palliative care, they can carry that one with them. Though sometimes there are no drugs, but it's only you are using experience and the knowledge you have so that people can get that knowledge and try to pass it and use it as palliative care in their own location. And also integration. Sometimes we see maybe nurses on the ward or doctors in the ward, the way they talk to the patients, maybe they can tell a patient, you are going to die. So you wonder how really the relatives will feel and how the patient will feel if you just tell the patients like that. So again, much more during maybe CMEs, we try to bring this idea of palliative care and tell them how they can handle these patients. Because these patients, they have a great experience whereby they cannot get cure anymore, but what we offer for them in a little way relieves them and makes them to live much longer and to be happy and being accepted in the community. So integration and advocacy is much more important. It makes people have a sense of creating palliative care wherever they are, no matter they are at home or whichever situations they are, they'll be able to act that way. Thank you.
Thank you so much. Thank you, thank you, thank you. We are at the top of the hour. I always love this with Pal is that there's more discussions, there's more energy. I want to profoundly thank Dr. Nahla again for all of your work, but for your presentation today. And I've seen in the chat, there's I got into this field the very first time I heard people say to patients, there's nothing more I can do. And with palliative care, there is always something more I can do. Even in the face of governments and ministries of health that don't get it, in resource scarce settings, we can support each other. We can advocate at, the international Geneva level, and we can act, think globally, act locally. Before our next webinar will be in January of 2026. If Aaron, I don't know if, let's see. Oh, there, Aaron, can you put up on the screen how to sign up, how to join us, our email. If you haven't been on our email list, we would love to have you. We would love to have you in one of our committees. If you would like to be part of advocacy work or communications work or research or education and training. And again, we try to meet monthly, quarterly, we all are volunteers. We all I have limited time, but we all have passion. And so whatever time you would like to contribute to this mission, we would love to have you with us. We would love to have you as a member, free, and to join us on our social media. And I'm 4 minutes over. Anything else from my colleagues?
Maybe Rick, as this is our opportunity, we don't get many chances to meet together. I'll just ask everyone to put their videos on if they're okay. This is our chance to celebrate World Hospice and Palliative Care Day. We know many communities around the world did it in person. We don't get that opportunity at PallCHASE very often. So maybe I could take a quick screenshot, and then I just have 2 announcements before we close.
Do you want to stop screen sharing so that we can, yeah, that'd be good.
If you feel comfortable to put your video on, you can smile. I don't know, we don't need to do anything too crazy. But I'll just take a quick screenshot. I know we had a few people drop off, but thank you so much for everyone that's still with us. So on 3, I will take a picture. All right, so smile, 1, 2, 3. Great.
Perfect. Thank you. Thank you.
Thank you, and happy World Palliative Care Day all.
Thank you.
I think that
Thank you.
Erin has just got a couple more presentations or
Yeah, I just wanted to
information slides to show.
Yeah, perfect. So just before you head out, we have 2 announcements that we wanted to share. So the Global Health Academy, which we are hosted under at PallCHASE through the University of Edinburgh, is currently doing a research study. So the study does take about 20 to 30 minutes to fill out, but they are looking for humanitarian healthcare workers to understand and better explore their learning needs. So the study is titled Palliative Care Education in Low and Middle Income Countries with a Humanitarian Context. And this research study, if you are interested in doing it, will explore humanitarian healthcare workers' learning needs. So I can also share with everyone who registered for the webinar today the link for this survey and study. And the team at Global Health Academy we greatly appreciate if you'd be interested in filling this out for them. The second announcement we wanted to make was an announcement that came out of the Botswana conference, the Africa Palliative Care Association Humanitarian Response Fund. And this is being supported by us here at PallCHASE, knowing that in Africa, we are bearing the heaviest burden of the world's increasing humanitarian crisis, whether it's climate-related, famine in Sudan, disease outbreaks, and conflict, just to name a few. Amid these challenges, and despite severe cuts, we know in international aid around the world and in our region, palliative care workers are performing their work and continuing to find ways to relieve suffering. This fund would go directly to support the work that is happening in the Africa region. So this enables the global palliative care community and Friends of Africa to provide direct support for colleagues working in these very difficult and desperate situations. So there's a QR code here. We would like, if you are interested individually in supporting this cause, we have that call out very strongly, and we would love for you to share this amongst your networks as well. We do believe that each one of you can make a difference in this work. Money and finances are just one way, but we do understand the great need at the moment. So please stand with us as we find ways to support the work that is happening. There's a link there. Again, I will email everyone who registered for the event so they can have access to that. But if you are able to and interested, you can also use the QR code to get more information. And I think we are finished. So we will definitely be in touch in the new year when our next event will be happening.
Thank you so much.
Thanks, everybody. So good to see
Thank
you.
you. Wonderful
Thank
to
you
have
so
you,
much.
Joy.
Happy World Hospice and Palliative Care Day. I guess.
Bye bye.
Bye-bye.
Bye now.